and it's going to stick around for a little bit longer, so again, my apologies. That's a picture of UVA, where I hail from. I went to school there, and it looks about like that right now. There are fewer leaves on the trees, and there's actually a big wet slosh from all the rain we had down the middle of that. But that's what we refer to as the lawn that Thomas Jefferson created many years and years ago, and we still refer to Mr. Jefferson as if he were alive at UVA, so bear with me if I mention him as if he was in the room. I tried to find a really wise Chinese saying, so I did what anyone would do, and I Googled it, and this is what I came up with. It actually ends up being pretty relevant to the points we're going to talk about today, because it mentions money, doctors, and health, and the disconnect between all three of those things, and that's an important part of what we're going to talk about today. The Center for Health Policy, and you'll notice that logo will appear in the bottom right-hand screen. It's not just an advertisement for our center, although it's also that, but it's also a reminder, because we're going to have a bit of a memory test today as we go through these slides, to remember the intersections of some of the things we're going to talk about in the overlap, and the logo is deliberative, as you'll see going forward. So, in my mind, the most important question in this arena and for the country is the social imperative of these topics of how do we make healthcare achievable, which is a major challenge, equitable, and sustainable at the same time. And it may or may not be possible to do all three, to be honest. But for everybody, and that's really the biggest challenge in my view, is to make it equitable and available to everyone. We have had a conversation in this country for many, many years about how to make it affordable, hence the name of the Affordable Care Act. But what we discovered, and I think you all are living this at the state level certainly, is that affordable and available are not necessarily the same thing. And that's going to continue to be true as we move forward. But there's more of an imperative than I think most people realize that is embedded in this whole conversation about healthcare and health and wellness in this country. And this story sort of brings it all to a rather harsh point. This is a story from NBC News' website 2-3 months ago, and we'll go through some details here in a second, but I hope you realize that this question of how do we achieve health, equity, and wellness is not just a matter of people being healthy or not being healthy, hospital costs, bottom lines. It's also a matter of, can we field a fighting force? So the story goes on to describe the story of a young man who's not my son, just for the record, not my son, who really wants to serve our country and join the Army, but Marcus is surprised to find that the Army doesn't want him at his current weight of 250 pounds. He's 5'10", I'm roughly 6 feet. He's me plus 1.5 inches or so and 60 pounds. And Marcus is surprised that the Army doesn't want him to serve in the Army at that weight. Marcus is also surprised that someone actually called him obese. And Marcus has the things that people who are obese deal with. He's got some asthma, which is probably mostly tied to an early version of chronic obstructive lung disease, or COPD, because the weight of his chest is so great that his lungs can't expand fully. He's got prediabetes, which is a condition, it's a term that we made up recently in American healthcare that just describes those who are on a path to becoming diabetic. And there are some markers we can measure in the blood that say that you're likelier to become diabetic in coming years if you have some of these endpoints already met, also tied to his weight. High blood pressure also directly tied to his weight, and the consequences of all those things are cumulative over time. So Marcus is facing a pretty bleak future if he doesn't do something meaningful to change his life. And thankfully for Marcus, the Army, he tried to join the Army, and the Army intervened. And the Army hired Dr. Greg Poland there 10 years ago, it turns out. So the Army's known about this problem for some while, and I think those of you in the room who have military bases may be aware of this. So they hired this guy who's developed a fitness and weight loss program for pre-recruits. These are not yet Army recruits. They have not yet taken the oath, but they're too heavy to serve. And it's a rigorous exercise program, and the reason being, as you see in the quote, in 3 years, which is 3 years is hard to say because 2017 is upon us already, 2 of every 10 recruits will be too heavy to serve. And he goes on to say that in the US, obesity and overweight is #1 cause of ineligibility. So the 4F failure of serving in the Army is no longer for things like flat feet. or vision, it's obese and overweight, lack of fitness. So the Army has this rigorous program where it's twice a day sort of P90X workouts, and I couldn't do a twice-a-day P90X workout myself. I'm 50, but the Army has invested a significant amount of money, not to mention just as this consultant, to have a fit fighting force. Because if only 2 of 10 Americans is able physically to go into basic training, let alone succeed in basic training, we've got a much bigger problem. Now translate that to your labor force in your states. If your labor force is too unhealthy to come to work, and we see this continuously right now across the country, obesity is probably a driver for a lot of that. Low back pain complaints through the roof, joint complaints through the roof, and eventually does become joint replacement surgeries, and eventually does become, God help us, back surgeries. So you can see how the dominoes begin to fall if we don't deflect this path in a much more meaningful way than we have in the recent years. So what I'd like to propose to you is that we've gone about this kind of the wrong way as a country. We've talked about healthcare access as if it was the end-all be-all, and it's very important. And there are certainly parts of your state, particularly those states like Virginia, that have significant rural areas where individuals live far from individuals who live really far from access to care, who live really, really far from tertiary care. You have that problem to solve, so that's an access challenge. But more importantly, I think we've missed the value proposition in healthcare. We've paid attention very much to how much physicians get paid, how much the government pays, how much state governments pay, which are all critically important issues. But we haven't really focused on what I would hope to convince you is the value proposition that we need to bring to this whole conversation. Because when you have value as the central goal of your conversations around healthcare, then healthcare disparities must disappear. Because it turns out that health disparities are really expensive. They're expensive to exist in your country, period. And I want to show you some data from around the world that says that we are not doing as well as we could be in that regard. In particular, because we have focused on, again, I think the wrong subject, the wrong issues. So you'll notice the recurring theme of the Venn diagram here, and the reason the logo is the way the logo is because of this picture. So we've done a pretty good job of talking about this, expenses in this country, and this, how much providers charge, how much we cost. And those are critically important things, and that's why they're on the Venn diagram. We've done a really bad job of talking about this. We have done a terrible job of saying to all patients, pre-patients, patients who are healthy, people who are healthy, what is your goal? What do you want out of this? So for example, if your goal for having your knee replaced is to have less knee pain, you may not in fact have less knee pain. And there's lots of science coming out now that knee replacement surgery is probably not as all it's cracked up to be for everybody. There are definitely people who need knee replacement surgery. My mom's had 2. She loves it. She wouldn't go back. But there are lots of patients who have knee replacement surgery and still have knee pain. So if their goal was to have no knee pain or less knee pain, we've failed them. And by definition, in my book, we've not achieved value because we're way on the top part of that screen at significant expense. And so I would propose to you that the solutions that you're going to have to undertake as a state, at the state level, really should start in the middle of this, but need to consider at least all these 3 environments. There's a separate conversation about industry that's really not central to this because it is not actually the job of state governments to necessarily make industry thrive or fail, necessarily. But if we agree that value is the most important thing and the central tenet, then industry will do well because they'll find the markets that they need to compete in and they'll thrive. So why does it matter? Who cares? Well, this is why it matters. And you've all seen some version of this slide somewhere. This way over here is us, and that's the expenditure per capita for US citizens, and this is recent data. Not the place the US wants to lead, obviously. It's the place the US has led for some while. But I will tell you that it's not as bad as it may seem if you look at other data, which we're going to go into in a second. But it's a place we want to lose. We want to not be the winner in this competition to be on the far left hand or this graph. We want to be somewhere more like here, ultimately. So if we are already leading in this terrible metric, is there good news on the horizon? I would submit to you there is. So now the US is there, and you have to kind of do a little bit of an eye test, but that's the US right about there. So the light blue line is the pre-2009 rate of growth of expenditure per capita in GDP real terms over time, and we have declined as a country. And so we are actually more like middle of the road when it comes to the OECD states I mentioned in the first slide. So we're making some progress in the overall expenditures as a country. Doesn't necessarily help you as a state, and we'll get into that in a second. But as a country, we've bent this curve to some degree in a meaningful and useful way. But these are still very macro conversations we're having. So I want to get down to the more personal level. Here's the problem. Here's part of the problem anyway. The green, or I mean the orange is, and I didn't, by the way, this is not my slide, this is from the Kaiser Family Foundation, so the orange and blue reference to UVA is accidental, I promise. This is individual family contributions to their premiums. This is employer contributions to the premiums, and you can see this curve, the trend lines are both steadily upward, and those haven't really changed. In fact, in more recent years, this line has gone a little bit higher, so that individuals and families are paying more out of pocket for their own care. Now, to be honest, and to be blunt, intuitively, that's not a wrong thing. Why should anybody else, logically, not historically, but logically, why should anybody else pay for my health care? Doesn't make much sense. And you'll hear about the evolution of health insurance and its various iterations over the history of our country here at the next speaker. But we have a disconnect that we'll talk about a little bit more, because this is not necessarily unfair, right? It's a reasonable thing that if I get something, I should pay something for it. Employers are saying, well, we can't afford this growth curve either. And so they're shifting their portion of this bar down here as much as they can. And that's happening at UVA, it's probably happening all over your states. Also not an unfair, if you think of it purely in logical sense, not an unfair proposition. But it is a lot of money. And certainly if you live at $11,000 a year total family income, that's unrealistic. Actually, any of those is unrealistic if you only go back to that far. So to ask a family that only has $13,000, $14,000, $15,000 a year to come up with anything like this amount of money is also unrealistic, which means they're going to not have health insurance, which means they're going to come to my emergency room in large numbers at UVA Hospital in all over your states. They're going to come to public hospitals, which are tanking all across the country financially, right? Just can't keep doing business, because while we are mandated to take care of those who don't have insurance and those who have not great insurance in the acute setting, which is the most expensive setting, there's not a mandate anymore, it's evolving rapidly, to pay us at cost at least. There was, and the DISH money that you're all probably familiar with, disproportionate share of healthcare services money is in flux. Depends on the state, depends on the program you have and negotiations you've had with the federal government. But DISH money never actually covered the cost of that care. So we ended up charging all of you who have health insurance and a good health insurance policy $17 for a Band-Aid in order to pay for John Q or Jane Q Public who didn't have insurance. And it's cost shifting. It's the hospital's version of cost sharing. It's largely invisible to the public, and you get this giant bill, and the insurer pays most of it if you have insurance. And you don't necessarily feel that bill, but not everyone doesn't feel that bill. And that's part of the problem. As you see here, this is just premiums. If you actually get sick, or someone gets sick and gets hospitalized and has a $17, $18, $19, $20, $250, $300,000 health bill, even the copay of that is a lot of money, particularly if you're living at an income level that's somewhere on the bottom part of this metric. So we have some serious problems to address as a country. So for all that money that companies, governments, federal and state are spending, are we getting much value? Again, you're in my value diagram from the first couple slides. Well, unfortunately, the answer is no. So the U.S. is very bottom line, and this is actually alphabetical. This is not a rank order for us. But in this slide, orange is bad, right? You want to be in the top third, so that's thirds up there in terms of performance. And the metrics are life expectancy at birth for men, women. If you hit 65, how much longer do you live for men, women, and then mortality from cardiovascular disease, which is becoming the #1 killer across the globe, by the way, it's not just the US. So again, in this graph, green is good. We want to be green. Green is good. We're not green anywhere. Right? We are in the bottom third for these very finite metrics, and I think most of you are probably aware that data came out, I think it was yesterday, about the life expectancy in this country went down for the first time in a long, long time, in a generation. Statistically speaking, I'm not too concerned about that number per se. I am very worried that the population that caused that is the younger fraction of the population, so younger deaths caused that number to go down. which is a terrifying concept. And you remember my story about the military. Obesity, suicide, depression, major causes of earlier and earlier mortality that we have not gotten a handle on as a country. So we're going to keep doing this. In fact, if you look at this mortality number, we're going to even get worse before we get better. So we're not getting value, was my point. We spend a lot of money, as I described earlier, we're not getting value. But that's sort of the federal level, and that's in the US. So that's the great disconnect, right? We're spending a whole ton of money as a country. We lead the world in spending money per capita on this, and we're not getting the results we like to have as a country. So is it all that bad? I mean, are we really that bad? And I would submit to you it's not that bad, and here's why. This is if you spend your social capital in two domains, social services and healthcare. And you can see that if you add those two together, and I would submit to you that you should add those two together, the US is pretty middle of the road right here. That's us. 25% of GDP spent in those two domains. And if you look over here at these countries who are spending a great deal more of it than combined than we are, we're better than that, right, in terms of percentage of GDP that we're spending. And this is important to remember that some of those countries are in the green. So Sweden, there it is. Sweden, green, 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 green. Switzerland, green, 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 green. France is up here somewhere, and lots of green and only one orange. So they are investing differently than we are and getting these results. And so we talked about disparities in healthcare. If you invest in your whole society, and I walked past the various rooms around the meeting today as I came down to the room, and I thought, that's important to my conversation. That's important to my conversation. Education, transportation, water, environmental changes, all those things as I walk down the hall inform our conversation today. You have to invest outside of this room, and you'll get to that slide in a bit, but you have to invest outside of this room in all those other areas if we want to become green in these. Because, as I said, these countries did and have better health outcomes and live longer, healthier lives than we do. Nothing is free. You got to spend the dollar somewhere, so you may as well pick your poison. And my recommendation to you is to spend it not in healthcare dollars. Don't pay me more money. I get paid penny. Pay your social services and infrastructure folks more money so they can mitigate these factors that are causing a lot of this disease burden we're talking about now. So that's federal compared to other countries. Let's talk about the states. You'll find your own state on there. And in this particular slide, light blue is the place to be. But you're all spending more and more money on Medicaid, which is not a big surprise. I think you're all about to spend a great deal more of your own money on Medicaid in the coming 2, 3, 4 years. So be prepared for this transition that will shift. I think the term that's being used is shift control back to the states. I would submit to you that control is a code for risk back to the states. And any of you who worked in the ACO space know what shared risk is, and this is the definition of shared risk. So as this number will necessarily change and get higher and higher and higher, and this graph will get darker and darker blue over time, that's the space that you have to work in, because the Medicaid population in most states is usually a relatively sick population. In Medicare, 5% of the patients spend about 60% of the dollars. Let's say that again. 5% of the patients spend about 60% of the dollars. Disproportionate spending. Medicaid is less of a pyramid, more of a column. So a relatively broader number of folks who are chronically ill, and then there's the whole conversation of the dual eligible folks who are Medicaid and Medicare eligible, which is its own murky place that no one's really truly figured out yet. And that's another imperative for us, because dual eligible people are also really expensive to take care of. Much better to have them never get sick in the first place, but that's now a generational challenge for us. So we move along to how much does that really translate into real dollars per enrollee. Same time period. In this graph, you want to be you want to be white, if at all possible. $10,500 per enrollee per year is a great deal of money, particularly for Medicaid patients who definitionally don't make $10,500 a year that they can give away, and all that money is coming out of some version of Medicaid. So the federal match coming out of the shared management program that you guys in your state legislature level manage. So one of the important parts of these statewide or the nationwide graphs is the variability you'll see. And so one of the major flaws in my view of the Affordable Care Act, although I think they figured this out when they wrote it, is that one size will never fit all in our country, or really anywhere. Because healthcare, like politics, it's all local. The solutions are all local. And so the variability you see here is not to be unexpected, but it is to be overcome. So I talked about the growth rate in spending per capita for the US. How about for your states? And again, this is the growth rate. And the growth rate of 4.1% on average across the country, and again, light blue is better, less growth in Medicaid spending is better for you as a state. And again, you see the variability. So we've got a significant disarray, if you will, on the state level. And in your own states, you all know this. It depends on the neighborhood, depends on the county, depends on the zip code, who's going to have the best health outcomes. But it's a state problem. And increasingly, I think it's going to be very much, and maybe even entirely, if certain rhetoric turns into legislation, entirely a state problem. State opportunity, I think we'd say in lean speak, but a state problem in real terms. So you can either spend your money and continue to spend your money in Medicaid, taking care of sick people, taking care of illness, or you can spend it in the social sectors. And so this is telling. Look at that map, remember the variability, and then look at this map. So I think most of you in the room know what TANF is. It's temporary assistance for needy families, and it has to do with food stamps and temporary housing sorts and a couple other things that would reliably be called by most people social services. And so here's the map of the states. And this is 2014 data. And you can see the variability of how much a block granted program, like TANF, states spend on things not intended to be spent for by the federal government. And so this is where some of my chest pain comes from the notion of block grants, is that you'll each have your own imperatives in your own state level conversations on legislature discussions. But the money is intended to mitigate the previous slots, right? The Medicaid spend, if you have a block grant. But there are other problems in other states, right? In your state, your problems are unique. And so if you look at this graph, many states, and several of whom that didn't expand Medicaid, at least not directly expand Medicaid, have spent TANF dollars in a way that they were never intended to be spent. Again, not for me as an individual to tell a state how to spend its money, but if you go back to my obese pre-soldier slide, very much for you to solve as a state. You have to be able to reconcile the fact that Sweden, the Netherlands, Denmark, to some degree the UK, outspend us in areas like TANF and have better health outcomes, and spend a great deal less money overall, at least in the UK, than we do. And how do you then support social services? In the European nations, social welfare is referred to more like social well-being, and it's the well-being of the entire society. That is not our version of welfare, as you well know. Many of us view welfare as an entitlement program that has negative connotations. I would urge you to rethink that, again, based on maps like this, where we have programs that are intended to help those who are clearly in need. We have to stamp out abuse and malingering, absolutely. But I think that's been pretty well proven to be a pretty small portion of those people who actually, no one wants to be on TANF. Show of hands, who wants to be on food stamps? No person wants to be on food stamps. I heard actually I read a blog post about a county, and anybody from Louisiana here? Okay, good. I trained in Louisiana. I spent 5 years in New Orleans and parts of western Louisiana training as a general surgeon in the charity hospital system in the early 90s. And I love Louisiana. It's my home away from home. It's a fabulous place. But the poorest county in terms of health outcomes, the worst health outcomes in the Dartmouth County Health Atlas map is in Louisiana. It's outside of Alexandria, Louisiana. Alexandria is a relatively small city in Louisiana, but this town is outside of Alexandria. And there's raw sewage coming up into the water, in the well water, and there has been for years. So it doesn't matter how much access to healthcare you got. If you have raw sewage coming out of your well water, you can be but so healthy. And surprisingly to no one, they have really poor health outcomes. So you have to solve the water problem. right? I think water was one of the signs I walked by on the way down the hall. You got to solve that problem in that county, or you're never, ever going to not spend Medicaid dollars, because guess what? It's also a dense pocket of poverty, right? Which kind of goes together. There's not a lot of sewage coming up out of the streets in Wall Street, or in Charlottesville for that matter, right? There's no sewage coming up out of my groundwater. So we've got to be aware of this whole picture, and we've got to be mindful. Because that's the second great disconnect. We have not talked about the social determinants of health in a meaningful way in this country. There are those of us who do research, and it's now becoming more of a buzzword, and I hope to convince you that that's probably where the money is. Medicaid spending is a self-fulfilling prophecy that if you keep spending money on people being sick, you can keep spending money on people being sick. It'll keep on going. So here is a list of some of the things that people have labeled, and this is from Healthy People 2020, this particular graphic. And you can read the list for yourself, but basically it has to do with the environment of living. Is it safe? Is it clean? Is there clean water? There's an education system that's reliable and safe to attend that produces a product that is able to compete in the workforce. And you can add in all the other things we talked about already today. And again, if you walk around the meeting, I guarantee you'll find the social determinants of health being talked about in other rooms. That's what those things are. And so this is the most important room. You've all chosen well. This is the most important room to be in. But it's informed by the walk to get here. So well done for making it that way. Good job to the program directors. But this is the most important conversation you're going to have in the longest while, because we're going to talk about insurance, and we need to talk about insurance. But if you don't address these things, if you don't end up looking more like Sweden when it comes to social determinants of health, where no one goes, not no one, but almost no one goes without clean running water in the country, forget the county, forget the state, where no one doesn't have access to a really reasonably good primary education, where no one doesn't have job skills training, and where no one doesn't have time to take care of their family when they have a family. If we don't solve those problems, we can never, ever not lead that first slide where we are spending all the money in the world in a treadmill, because that's what we're on now. And there's been lots of talk about Medicaid expenditures, and so the reality is if you give them insurance, they will come. It's like the movie. If you build it, they will come. Well, sure enough, if you give people access to insurance, they will get insurance, and they'll spend it by going to the doctor, going to the hospitals, et cetera, and we will take their money, I promise you. If you bring me Medicaid dollars, I will spend Medicaid dollars. If you bring me commercial insurance, I'll spend that first, right? What I can't spend is no money. So if you all of a sudden, in episodes where the US economy tanks, have more people who slip into Medicaid eligibility, Medicaid expenditures will go up. So it matters very much that the macroeconomy, and in your cases, the state economy, is healthiest. Because you can see here that when the economy is healthiest, Medicaid expenditures go down. When it's not, they go up. It's really pretty linear. So social determinants of health, I hope to convince you, are important, but how important are they? Well, if you ask the Kaiser Family Foundation, and really everyone else who studies this work, it turns out that these two sections, the orange and blue, again, not intentional, I swear, this one and this one, 60% if you ask Kaiser Family Foundation, 75% if you ask other countries and other researchers, 3/4 of what impacts your health and well-being is not this. It's not me. It's not me as a trauma surgeon. It's not me fixing your gallbladder, fixing your hernia. It's these things that we talked about in the hallway walk you took to get here. So if we don't really begin to invest in this, and again, this is a very local solution. The federal government can never figure this out for you. And I don't think they should try. Right? This is going to be a local solution, a local problem. But you may be on your own in this, right? That's a real dangerous place to be, because as a state government particularly, your mechanisms and tools are limited. Unless you run hospitals in your state, and some of you still do, where you actually have state hospitals that you run, there's not much you can do to mitigate these things from the Medicaid expenditure. Or can you? So happily, you have places like UVA Health System. Medical centers that are academic, that have a research mission, a teaching mission, and a philanthropic mission. We're almost all nonprofits. Use us to that degree. We almost all make money too, let's be honest. So here's some examples of medical centers around the country that have partnered in unique ways to mitigate the social determinants, as you can see there. And I'm sorry, the slides looks a little blurry, but the areas are basic necessities, and you see a food plate, built environment, housing, education, community support, and economic stability. Gunderson Health System in Minnesota has partnered with communities by working with local restaurants to help them improve their food choices. So they didn't build a restaurant, right? The Gunderson didn't go out and build Gunderson's, Big Mac competitor. They went and said, let's take our academic brains and see if we can't help you improve your menu choices that'll still taste good, but will not be as ready fodder for the obesity crisis that we're facing now. The next one is an example from Henry Ford Health System in Detroit, partner with several institutions and several NGOs in Detroit to improve the local neighborhoods and develop safe and affordable housing for residents in certain parts of Detroit. Again, if you have no safe place to live, it's almost impossible to be healthy. Henry Ford didn't build the houses, but they helped folks build the houses. This is one of my favorite ones. Hopkins, up the road from us in Baltimore, partnered with Morgan State University, which is a historically black college, also in Baltimore, and they actually did build a school in one of the roughest neighborhoods of Baltimore, and they teach in that school. So their faculty teach in the school. And to provide the education for the next generation is one of the ways to break this cycle of poverty that we've been talking about over and over over the course of the day. So, and there's a couple of examples in there, but you get the point, right? You can partner, for those of you who have, and almost, in fact, all of you have the University of fill-in-the-blank state health system as a potential partner, many of whom, like UVA, are state properties. The state of Virginia owns my health system. It's a complex relationship, don't ask me, but they own the health system. We actually pay, I think, $1 to the state a year, and they send it back to us as reimbursement. But you all have one, and you actually, many of you have more than one. And I would urge you to reach out to those AMCs in your states and say, help us solve this problem. Don't build 14 more MRI machines because someone's got to pay for that, and I got news for you. If I get an MRI machine, you're paying for it. Right? We're all paying for that MRI machine. It's not like the CEO's got a personal checkbook and she's just sitting there going, MRI, free. We get money from sick people. That's the model in this country. Health systems, doctors in particular, we get money from sick people. There's no money to be made in health and wellness. Just be honest. Money isn't there. But there's money for the society. And there's growth for society, and there is security for the society in health and wellness, and that's where we need to focus our attention. And the last thing I want to talk to you about is the major gap that we haven't talked about is how much this stuff costs. So I've been to the doctor, I've been operated on by my colleagues, I picked my surgeon on the phone on the way in, I said, Pete, take out my appendix, he came, took my appendix out. I got a bill. I read the bill, I said, good thing I have insurance and not paying that bill. I didn't know how much it costs. I take out appendices all the time. So one of the things I do, no idea how much it costs. I've had 3 patients I can remember ask me, how much is my operation going to cost? And my answer is, I don't know. Because I don't decide that, right? And most physicians, unless you're in private practice, don't set their fees. That's a business office, that's a practice plan, that's some entity that is not the individual interface between the patient and the doctor who sets the fees. The other piece of that is patients also don't know how much stuff costs. Right? So it's a tough combination. When the patients don't know, they spend money in healthcare, and the doctors don't know, we spend money in healthcare. I pick my devices, I pick my instruments, I pick my gloves, I pick my antibiotics. I spend money, and I order radiology tests. I'm a spender of money in healthcare systems. Patients come to me for these things. They are spenders. The 2 people who spend the money don't have any idea what the costs are. So I didn't make this up, right? If you look at this little paragraph here, it's really disturbing. It's also not old. When you give me a choice of really cool things to do to people and you give me the price, it turns out that my colleagues, more often than not, pick the most expensive thing. So the Rolls-Royce phenomenon, if it costs more, it must be better. This is also true of patients. Patients also will choose the most expensive thing if they're not paying for it. Right? If somebody else is paying for it. So this has been studied in actually this calendar year. Great paper came out that said people were given 3 choices of a procedure, a gold version, a silver version, and they called them gold, silver, and bronze on purpose. That was part of the study design. And they said the results will be exactly the same. You'll have the same outcome with the gold, the silver, and the bronze. Which one do you want? 3 guesses, right? Who wants to be the bronze medalist at the Olympics? All right, let's be honest. That's what happens. In part because, as I mentioned earlier, no one knows how much this stuff costs, and we don't feel it, but we are beginning to feel it. You're in my orange and blue slide earlier. People are beginning to feel that cost. And we're now beginning to say, whoa, 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 whoa. And that's a crucial conversation. And at your level, the state level, it's going to be the conversation. Remember my Venn diagram, remember my logo, it has to be overlapping where the patient's expenses and goals, what I can afford to do and my outcomes, and what the payers can afford to pay, where those three things overlap, that's what value is. And it may well not be another MRI machine, or an MRI test, or even surgery, or life-extending chemotherapy. We're gonna get really crazy now, right? If you already have a terrible, terrible disease, and you can get 3 more weeks, 3 more months out of it and suffer, is that value for you, the individual, right? And these are hard conversations. We're gonna have to have them because we can't keep winning that race to the bottom when it comes to spending money on healthcare dollars. So what I think the future state's gonna look like is something like this. You will have more control at the state level. Translation, you're gonna have a lot more risk. You're gonna have to be handling risk in a way that states have never done since we invented Medicaid, basically, if the rhetoric turns into legislation, into policy. You're gonna spend more money in healthcare dollars, plain and simple. That's what's gonna happen. The only question is, what's the growth rate and the trajectory? And then can you, over time, mitigate the determinants of health that we talked about earlier to bend that curve in a way that actually gets it to not only slow down, but maybe inflect downward. That's the meal target for you as a state. The opportunities will be there, though. And I think one of the unsung heroes of the Affordable Care Act is the 1115 and 1332 waivers, and some of you may be aware of those, that many states took advantage of to great effect. So states that chose not to expand Medicaid in different ways without having to call it Medicaid expansion, and well done. Texas is one that did, or has done some really good leveraging of federal dollars. Arkansas is probably the most notable success story that I'm aware of that did expand Medicaid, but has tremendous outcomes by not spending dollars in hospitals. Community health workers who go into their communities and help people make their appointments. They give them rides to the doctor. They give them rides not to the ER, but to an office building. Those kinds of things are the kinds of solutions that states uniquely are positioned to put in place. And I would urge you to consider your local problem solving to be a local opportunity to solve those problems and partner with universities in your states. We can help you do this work. Thanks for your attention.
At this time, we will continue with the next speaker and hold the questions to the end, especially the crystal ball questions about the new